repeat it.
Hold that thought.
Don't forget it.
Don't
Okay. That's a pun based on the. Okay, we're back. Senate Health and Welfare, and we're continuing the day with S302, and we have the sponsor, Senator Brock, with us. Thank you for being here. Welcome.
Thank you. It's Senator Randy Brock, and thank you for having me today. Have you talked about this bill at all yet?
No, this is it. You're our introducer to the bill. We appreciate that.
I'll try to fire it up if I can remember what to say.
Well, give us the global perspective on the bill, where it comes from and where it goes, and then Katie can walk us through.
Sure, absolutely. Just overall, this is a bill about Alzheimer's disease. And I think we all know about Alzheimer's. It's hard to find anybody who has not been touched by Alzheimer's here in Vermont, either for a relative, somebody, a family member, a friend, or the economic effect of Alzheimer's disease, which is an extremely costly disease, both directly and indirectly. It tremendously affects the people who have it, obviously, and has an effect on their lives. But it also has a tremendous effect on their families, and on the economy, and on the amount of money that we spend, not just for care, but also for support, and also for the family members who are involved, who often wind up needing care and respite themselves. The numbers of Alzheimer's disease in Vermont are staggering. I got a note here on some of the more recent statistics, and it's saying that now about 13,000 people are age 65 or older have Alzheimer's, and it is a disease of old age. For Vermont, as the second oldest state in the nation, we're particularly afflicted by it. We have a problem about Alzheimer's care, as you know, in that for the long-term custodial care that is often necessary, unless people have long-term care insurance, which is something that's relatively new, they almost have to be impoverished in order to get what's necessary to provide care. And that too is a problem that we're looking at. This particular bill, though, is very limited in scope, and it's limited in scope to talking about awareness and providing information both to the public, but also to the medical community, because time and time, and I've been involved in Alzheimer's and the disease, both as president when we had a Alzheimer's chapter directly in Vermont, to a member of the National Board of Directors of the Alzheimer's Association, and also as someone whose father had Alzheimer's disease and died from it, and whose wife's mother had Alzheimer's disease and died from it. So I've seen it close up as well as at a distance. This is a bill about awareness. It is a bill about ensuring that the Department of Health, the Department of Aging and Independent Living is focused on, among other things, ensuring that we have information provided both to the public and in particular to the medical community, because that's something that we don't pay a lot of attention to. And in the stories that come back about how people are counseled about Alzheimer's disease and the possibility of it, there are some deficiencies there too. Getting good information out is absolutely critical, and it ultimately has a return on investment because A, it gets care to people more quickly before they get into trouble, get into an accident while driving, or have some other kind of major problem, and that they get care because their local physician, their primary care physician, has enough knowledge about what to look, not just what to look for, but actually goes and looks for it and reports and acts accordingly. And what this bill does, it doesn't cost tons of money, which is my favorite kind of bill. It
didn't cost tons of money. Does that mean it costs pounds of money?
Maybe ounces.
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 Okay.
It's very small.
I'm saying that for my two colleagues.
It doesn't cost a lot.
Well, you hopefully, though, and we haven't calculated here, hopefully it has a return on investment. Because if you catch Alzheimer's early and you present more costly disasters, the need for more costly interventions later on, that also has a potential return on investment. And certainly one of the things you want to do in Alzheimer's with education is train the family members as to how to handle the disease so that it doesn't have the effect on them of taking them out of the workforce for a variety of reasons, ranging from stress to lack of planning to be able to handle the rigors that are associated with the disease. So that's what this bill does in a nutshell. I see that folks from the Alzheimer's Association are here, and I know other professionals, and Katie can, of course, take you through the details of what the bill says and does, but I hope it'll be of use and help all of you.
Thank you. Questions for Senator Brock? Go ahead.
If I can, just curious, are we targeting a certain subset of the population, or are we targeting just a blanket awareness?
It is a broad awareness process on the one hand, as far as the public is concerned, but it's a specific awareness program that is different for medical providers, and provide those medical providers with the information as to how best to deal with patients, how to deal with family members with Alzheimer's disease. And there appears to be, certainly based on what I hear anecdotally from people and have heard for a long time, that's an area in which we're deficient.
Thank you.
There's another component that I've experienced too, is that a financial stress on the family, because if they don't plan and prepare in the event of Alzheimer's, there's a certain period of time when property needs to be transferred legally to the dependent.
That's absolutely right, is because so often what happens is when people get into the late stages of Alzheimer's care, in which they need custodial care that may be too much for many households to deal with in the family. The only way to get that kind of care is essentially to be so impoverished, if you will, that you are reliant on Medicaid. And at that point, that has a tremendous financial effect on the entire family. There are ways to avoid it, to plan for it, but it has to be planned for, particularly in terms of moving property from one name to another. It has to be done somewhat far in advance, so you can't wait till the last minute to do it. A lot of people don't know that and don't take advantage of the possibilities to perhaps at least save some of their assets.
So as we look at the bill, is there anything in the bill about notification about this type of information?
No, I think the bill is more
Mostly
general in terms of information, because I think the attempt was not to, in effect, load everything to every detail, but to leave to the flexibility and also as information, as science, as treatments are changing, to not lock it up in infinitesimal detail. We do that across the hall in the other committee.
Oh, yeah. Oh, no. All right.
So thank you very much.
Thanks for coming in. This is great, and for introducing the bill. So we'll hear from Katie and walk through and see what we can do with it in here. Thank you. Have fun in your other committee. Well, Katie, why don't we go through 302?
Good morning. Katie McLean, Office of Legislative Counsel. Let me share my screen. Okay. So we're looking at S302, and we're adding it to an existing section in Title 33, which has to do with public education resources. So I'm going to go through the existing language so you know it's already in statute, and then I'll walk you through the new language. So currently, the law directs Departments of Health and Dale to jointly develop and maintain easily accessible electronic, print, and in-person public education materials and programs on Alzheimer's disease and related disorders that serve as a resource for patients, families, caregivers, and healthcare providers. The departments shall include information on the state plan on aging, as well as resources and programs for prevention care, support for individuals, families, and communities. So that's what's already in statute. And this bill adds a new subsection, and it directs the Department of Health, DMH, and Dale. So DMH wasn't included in the existing language. In consultation with the Commission on Alzheimer's Disease and Related Disorders, and other relevant work groups and community organizations. They shall, as part of existing and relevant public health outreach programs, first educate healthcare providers, and then there's a list of what they should provide, the information to provide healthcare providers. That includes the value of early detection and timely diagnosis of Alzheimer's disease and other types of dementia, validated assessment tools for the detection and diagnosis of Alzheimer's disease, younger onset Alzheimer's disease and other types of dementia, The benefits of a Medicare annual wellness visit or other annual physical for an adult 65 years of age or older to screen for Alzheimer's disease and other types of dementia. The significance of recognizing the family care partner as part of the healthcare team, and the Medicare care planning billing code for individuals with Alzheimer's disease and other types of dementia. And then there's also a requirement that the departments provide additional information to increase public understanding and awareness of. So this is public education. The first item on the list, the early warning signs of Alzheimer's disease and other types of dementia. The benefits of early detection and timely diagnosis of Alzheimer's disease and other types of dementia. And then we have language that, as part of this public outreach work, the departments are to provide uniform, consistent guidance and non-clinical terms with an emphasis on cultural relevancy and health literacy, specifically targeting populations at higher risk for developing dementia. And that is it, July 1 effective date.
Okay, so this is we need to hear from 3 different departments. And we need to hear from the Alzheimer's folks on this. Questions for Katie regarding the bill?
I'll ask a few questions. I'm not sure if this is for Katie or you or both, but in terms of providing the cultural piece of this, would we need to loop in the Office of Racial Equity as well?
Safa?
Okay, that's one question. And the other one is just now that I'm a seasoned veteran, having spent 1 session here in the Senate, I look more closely at dates, and I would just want to hear if that date is realistic. Because I'm sensitive to people seeming to be quite stressed out right now and under a lot of pressure. So I would just, when we hear from folks, we can ask.
That's a good question to ask. How would this all happen? And we're going to hear from Department of Health and Dale, DMH, and one can. It takes effect, so explain takes effect.
Oh, well, actually, I just had a thought about the cultural language as I was reading it. When the Health Equity the Health Equity Advisory Commission was established, I think they used the term cultural competency in that statute, and I think it might be defined. Don't quote me on any of that, but it might be worth looking if that is the language used, and if it is defined using the same language and adding a cross-reference.
They issued the report, so I'm thinking maybe we'll invite the chair of that committee in and look at the report and ask some of these questions.
Great. I think you're right, Katie.
Does that, it just rang a bell as I said it out loud.
So instead of relevancy, it would be
cultural competency. There might be a reason that I'm not understanding why relevancy was chosen, but I think it's cultural competency in that bill.
Great.
Act.
Okay. Other questions? So my question is the committee interested in taking testimony on the bill? Because it's the first time we've looked at it.
I am.
Okay. And then we'll have to get a fiscal. Yeah.
I think it's appropriate.
Yeah, no, I think this is good. The older the state gets, the more we need to focus on some of the aging issues in front of us.
We've done 2 bills in the last couple of years on Alzheimer's, so this is just adding on, and I think also helping us be in compliance with some of our federal grants and work in it. So,
As a novice to that point, can we hear that background? Just a couple minutes of, what is the history?
Well, what did we pass? Was it last year or the year before? Last year, we passed a bill and we had patients and families in talking about, we'll hear, maybe, I think the right person to ask that question of is maybe Meg.
yeah, I think we've done 2 bills, 3, I remember number S306.
Right. Oh, gosh. There's a memory. That's good.
So, we've done several, at least 2 bills, I think, since I've been on this committee on Alzheimer's. So it's just,
Did it pass?
So,
Yes.
I think, why don't we just take a minute right here and we have Department of Health, we have Department of Mental Health, we have Alzheimer's, and we have Dale. We have and Dale is here, we have DMH. is
Oh, the
not here.
family's all here.
The family's here, good, great, thank you. So, would you like to make a comment about the bill at this point? It won't be formal testimony, but just some comments about any thoughts you have for improvements to the bill off the top, or, hey.
Go ahead.
The only thing I would note is that,
For the record,
for the record, so Brenda Atwood, Department of Health Policy Director. The department has a lot of this information already on our website, so this seems feasible. I want to check with the program about where they think we might be able to improve this bill. But from the outset, it seems like a
Doable.
feasible way.
Yeah.
And for the record, Rebecca Silvernail from Dale, our dementia coordinator is going to start soon. So I would want her to weigh in on that.
Okay.
This was something that was part of last year's budget, and I believe she's starting next month. Not sooner, Monday.
Oh, we could have her in on her second day of work.
Should we, yeah, so, it would definitely fall under, her.
okay, well, and so as we take the bill up, we'll make sure that you're all scheduled in on this.
Yeah, she's already with Dale, but
Okay.
I'd like to.
Trial by fire.
Yeah.
Meg, any comments you'd like to make?
I just think, Meg Polite, Alzheimer's Association, regarding the comment that Senator Hardy made, I think it would be valuable to invite somebody from the Alzheimer's and Healthy Brain program, which is the program we're running with our CDC grant. And this is aligning and codifying the work that's being done there. And I think they can best answer sort of how they've already been doing this and where they think that it could grow if it was codified to expand it a little bit more.
Okay. So make sure that Kiki has that information, so when we put it up, you'll have all of it come in. That's good. All right, good. So we'll get this on the agenda sooner or later, and follow through with testimony. We've got folks from the health equity environment. We have folks from Alzheimer's, Dale, DMH, DOH. Good. And if there are others, if there are people out there who, Meg, I'm looking at you in particular, out there who've had experiences where more information would have improved outcomes or quality of life, that would be helpful so we can hear from families. It's hard to hear from patients all the time. I know you brought them in here last year. Was it last year or the year before? Both times, yeah, all fuses together, so that would be helpful. Okay, so we're gonna move along to, I thought it would be helpful for us to go through, I'm gonna shift we have 3 bills that Katie is working on with us. I thought we'd keep our mind set on oh, thank you. I just got Katie's email.
Read my mind.
Yeah.
That's the bill from Act 113 from 2022.
Okay.
So you have, I just sent it to your inbox, so now you can
Terrific.
have a little light reading.
So why don't we go to, is S-192 something that we can walk through yet again? And really start getting into the detailed consideration and markup, the idea of making some decisions, and do that together? We'll start with 192 and then we'll move on to the other 2. See how far we got.
So I flew out of my office and over here
Take
very
your time.
quickly because
Take
I
your
was
time.
putting together these charts and I was
Oh, the
consulting up to the
diagram.
last minute to make sure I'm hopefully not going to confuse anyone with these charts that I put together in S-192. So again, I should say Katie McLean, Office of Legislative Counsel. I do have a new draft 6.1, but I have 2 flow charts. I have a comparison chart. I have a Venn diagram. So, where would you like to start?
That's up to you. I am, we are open for
Okay.
your thoughts on that. And it probably begins with a side by side or the
Okay,
comparative analysis, and then it goes to the Venn diagram as we hit those places in the
Okay.
bill.
okay. So here's what I'm thinking. I'm gonna pull up the 2 flow charts. We'll walk through each of them, and then I'll show you kind of a word comparison chart that hopefully gives you the same information in a different
Without being
format.
too confusing.
Wait, you have a word cloud too, Katie?
No, like a Word document. Oh, goodness.
So, we don't have this stuff up on our.
You do.
It is there now. I just
you
refreshed
refreshed
it. Yeah.
So we have 2 pages here with similar looking chart in each. So the first one is the mental health process. If somebody is going to be committed to the custody of the Commissioner of Mental Health, and that process is being initiated in the criminal division versus out in the community. And similarly, we have a chart applicable to intellectual disability when there is a commitment process that is beginning in the criminal division. So if you start way over to the left side, we have as part of the court process, if it comes to the court's attention that somebody may need an evaluation, there is a forensic exam. And if ultimately it's determined that a person is incompetent to stand trial due to mental illness, there would be a commitment hearing at that point under 13 VSA, that's the criminal title. But all of the process is in Title 18, which is why we're amending so much in Title 18. So that is the commitment hearing, whether or not this person with mental illness meets the statutory definition of a person in need of treatment. So once they're committed, again, it's 90 days for initial commitment. It could be an order of hospitalization, an order of non-hospitalization, and if the commissioner decides before the expiration of the initial commitment order that the person likely needs continued treatment, they can apply for that. So I have these arrows kind of going in lots of different ways, because there's also in the mental health context an application for involuntary medication. And the process might not necessarily march along in this order. It could be that involuntary medication is applied for during the initial order. It could be that there's no involuntary medication applied for ever. It could be that there's no medication applied for in the initial order. A person is then ordered for continued treatment, and at that point in time, the commissioner applies for involuntary medication. So sort of at that point, it's less of a line and more of, a tree with branches, lots of different options. And then there's an administrative discharge once the commissioner finds that the person no longer meets the criteria for commitment. And then I'll scroll down to this intellectual disability chart. So again, we sort of start in the same place.
Let's go back one step.
Please.
And how does that discharge from commitment relate to competency to stand trial, if at all?
So they're sort of 2 separate determinations. So the Commissioner of Mental Health is making a determination, a clinical determination, a medical determination. Does this person still need treatment? They're not looking at whether the person is competent to stand trial. They're looking at whether the person is meeting the medical standard to continue to be in the Commissioner's custody.
So,
okay. And then intellectual disability. So we're starting in the same place. The person is criminally justice involved. It becomes apparent that this person may be a candidate for a forensic evaluation. That happens, and there's a determination that the person is incompetent due to intellectual disability. At that point, it's automatically kicked to a hearing in the criminal division for commitment. Right now, the language is that in indefinite or limited period for that initial order. A person has an option to commence a judicial review of their commitment 90 days after an order. If they don't do that, there is an automatic annual judicial review in the family division as to whether the person still needs to be held. That arrow is there to sort of say, like, it's going to happen again and again. Every year there's going to be that judicial review. And then there is an opportunity for either a judicial discharge or an administrative discharge. So there's a court process to have the person leave commitment, or there's the commissioner can make that determination. And now that I'm sort of saying this out loud, it could be in the mental health context also a judge saying that this person is not meeting the standard either. It's not just administrative. It could be either.
Intellectually incompetent, I'm thinking, what happens if it's somebody that's deemed intellectually incompetent and they happen to be developmentally
Intellectual
disabled?
disability,
Hmm?
intellectual
Yeah,
disability.
correct, and they're in a guardianship program,
Mm-hmm.
involuntary. Is that gonna be a problem for the Commissioner, Dale? Because we're under the control of the.
I'm going to refer your question to the attorney for Dale. I don't
Okay.
have an answer to
So,
that.
Stuart, are you there? Stuart Sure? I saw him there earlier.
Yes, I'm here. Sorry, I was having some
Oh,
technical
okay, so
issues again.
Senator
always
Williams,
Good morning.
gotta be, you have to know what's behind the screen. Thank you for being here. Senator
Sure.
Williams has a question for you. If you want to restate your question for him.
So does the Commissioner making determinations of regarding commitment timelines for somebody who's under developmentally disabled, they're under guardianship program, but they've created a criminal act? Is that gonna hinder the process for the Dale Commissioner if she has to do the referring and she's also the guardian?
I guess I'm not really understanding the question. So maybe this will help. So, if someone's under guardianship, that's different from being in the commissioner's custody. So one can be committed to the commissioner's custody, and when they have far fewer rights, frankly, than someone who is in the commissioner who is under guardianship. So one could be under guardianship but not committed to the custody of the commissioner, and one could be committed to the commissioner's custody but not under guardianship.
Okay.
So I don't think I see any issues with your scenario. Okay. But if someone else thinks I'm not answering the question, maybe they could help me out, because
The part of the question was about developmental disabilities.
Right.
Rather than intellectual disabilities. Can you discriminate between those two in this flow chart?
Okay. Right. So in order to be committed to the commissioner's custody under Act 248, one has to have an intellectual disability, which is a subset of developmental disability. So yes, one can be committed to Act 248 with an intellectual disability, and could also be, in the commissioner's custody as a result of that intellectual disability, or they could have, for example, autism, which would make them potentially eligible for guardianship, but would not make them eligible for Act 248, unless they have sub-average intellectual functioning as well as autism. But
so could they commit an offense that would put them in the forensic examination?
I see. So if a person is under the commissioner's guardianship and commits an offense, would that present a conflict for the commissioner to place them in Act 248 or make a recommendation? That's an excellent question. It is ultimately the state's attorney and the defense attorney and the judge who make the argument to the criminal division as to whether someone is going to be placed into the commissioner's custody under Act 248. Dale does have standing at those hearings to make an argument that that perhaps there's not a program, designated program for that individual that can be provided. But there's generally not an argument as to whether that person has an intellectual disability or presents a danger of harm to others. So there could very well be people in the commissioner's guardianship who are placed in Act 248.
Okay,
And that doesn't present a problem.
okay,
Does that help?
thank you. Yes.
Yeah, good, okay, thank you. Thanks for being available, that's good.
Sure. Of course.
Back to your diagram.
Shall we go over some more charts?
Yeah, good, good.
Okay. Let me share this document. This is a comparison chart that I hope sort of gives you the same information,
Okay.
with words instead of pictures. So this first row is the steps immediately after the forensic exam happens. So, no, I updated this. This is the wrong version. Darn. Okay. I don't know why I didn't saved it on my other computer. Okay, so this block I'm gonna have to update, but this block under mental health should be that there is a commitment hearing under Title 13. So that's what we looked at in the flow chart, that after the forensic exam, it's been determined that the person is incompetent due to mental illness, and then there's a commitment hearing that would happen under Title 13. In the intellectual disability context, the hearing for commitment would occur in the criminal division automatically. It would be an automatic hearing. The initial commitment term for mental health is up to 90 days, intellectual disability, indefinite or limited period. And then we move on to continued commitment. So in the mental health context, that requires the filing of an application for continued treatment, an ACT, to be filed before the prior order has concluded. In the intellectual disability context, the judicial hearing occurs automatically within 1 year.
Can we do something? Can we slow down?
Yes.
And can we go back to mental health
Sure.
and go slowly through that table one more time?
The flow chart?
The flow, I'm on your table. I'm on that you have up there.
Okay. Do you
And
want
just go through the mental health one more time.
only mental health?
Yep,
Okay.
please.
Okay. I'm frustrated because my updates didn't save
You don't
here,
like
so.
yeah, I know you don't like that first box, but
I know.
it does say commitment. It does say commitment. You're
It's not exactly right. I'll have to send the corrected version to the committee.
All right.
So mental health context, there's the forensic exam, for a person who is criminally justice involved. They've been potentially charged with a crime. It's becoming obvious that the person may be a person that's not competent to stand trial. There's a forensic exam. It is indeed determined that the person is incompetent to stand trial due to mental illness. What happens then? Then there would be a commitment hearing under Title 13, the criminal justice title, which has a cross-reference to all of the procedures in Title 18.
So, and the determination of competency to stand trial is separate from the clinical determination about mental health.
Yes, the commitment hearing is about the person's clinical treatment needs. Competency is whether the person can participate in their defense, if they can understand and work with their attorney, if they can understand the charges against them. So those are two different things. So at this point, when commitment is being looked at, there's already been a determination on competency. And now we're looking at, okay, what type of treatment does this person need? Does this person need to be in the custody of the Commissioner of Mental Health? If the court finds, yes, this person does need treatment, they will have an initial commitment order. The initial commitment could be an order of hospitalization, could be an order of non-hospitalization, and it can be up to 90 days. If the commissioner, before the first order expires, says, oh, this person actually is going to need treatment for longer than the initial period, then the department files an ACT, an application for continued treatment. And if the court grants that order, it looks also still looking at a medical standard, then that order is issued for up to 1 year. And then there's, in the mental health context, involuntary medication. That's a court process, requires a court order. And we have different circumstances that are listed in the bill of when it's appropriate to file for involuntary medication.
So you, but all of this is involuntary. So there's a specific thing you have to do for involuntary medication, but the whole thing is involuntary, right? Treatment. Yeah. So it's not like somebody saying, oh, I want to go to the forensic facility. It's that the court is ordering them to go to the forensic facility, right?
Yes.
Okay.
It could be in order to go into the community, a residential facility. If they've committed a heinous crime, then we're talking forensic facility.
Okay.
Okay.
Next, I'm going to go to the last column. So intellectual disability. So again, we're at the point where the forensic exam has been conducted. The person is incompetent to stand trial. There's automatically a commitment hearing that occurs in the criminal division for commitment to the commissioner's custody. If, again, that's a medical determination, what are the person's clinical treatment needs? If the court says, yes, this person should be in the commissioner's custody, the initial term is the indefinite or limited period. So that's the language in statute right now. Within or 90 days after an order for commitment, a person can have a judicial review of their need for commitment. So that's an option. If the person doesn't take that option, there would automatically be a review of the person's commitment at the 1 year point. And that would happen every year. So if the person needs commitment for multiple years, there would be that review at the 1 year point. Again, they're making a clinical determination at that point. And then we have, if the court is doing a judicial review and they're saying, yes, this person still should be in the care of the custody of the Commissioner of Dale, the order is, again, that indefinite or limited period. And involuntary medication is not an option for this population.
Not for intellectuals.
What happens if there's somebody who fits both categories? Would it have to be that the court decides you're in this lane or this lane?
That's interesting. I would ask the departments how that is handled. I'm not sure how that would be addressed.
Okay.
Now,
You want me to-
frequently we'll ask Stuart.
Yeah, I'm
Can I
sure it's
ask
not
him now? Are you
probably
interested?
rare,
Do you
but
want to ask that question now, Stuart?
sure. Stuart's gone.
No,
Stuart, he's here. He's here. I
I'm
knew he
here.
was there.
I'm here. I'm just a
And
little slow
Karen
on the click.
Carter is here, but this is a question for both of you because we have an overlapping patient. So Senator Hardy has a question.
Did you hear what I asked, Stuart?
I did, Senator, thanks. It's
Yeah.
probably more appropriate for Karen, only because Dale doesn't deal with medications of people with intellectual disabilities. But there is a court process by which the Department of Mental Health can request involuntary medications. So maybe Karen has more experience with that issue.
Well, it's not just involuntary medication, it's the whole process. If there's somebody that fits both categories, who's got intellectual disabilities and also mental health, which lane do they go in on Katie's chart, essentially?
Sure.
Just easier.
Right. Oh, I get it. So it's ultimately up to the court which lane. If at the commitment hearing, either DMH and or Dale can argue, or the state's attorney or defense attorney can argue that the individual will be placed in either of the commissioner's custodies, and it will be up to the court to decide where that person would go. So if there isn't, they would have to meet the criteria for one or both.
Right. And so what we look at when we're considering that is what is the primary diagnosis. So certainly we have people that have both. If it's primarily mental health, then mental health is seeking to take the lead. If it's primarily intellectual disabilities, then we're looking to Dale. Our teams do meet, I think almost weekly, about the folks that are kind of in this population who have been found incompetent, and we're looking at where they go. So mostly it's a clinical decision based on what is most appropriate. And so it could be, normally the departments kind of have a plan going in, and let the court know which one we think is appropriate. The court could overrule that, right? We could say we think an ONH is appropriate, and the court could say, actually, I'm going to do 248, but generally courts are going to take our lead.
Got it. And so there's nobody who's under the care and custody of both commissioners?
No, they have a primary.
Okay.
They may be receiving services from both, but they have a primary commissioner.
Got it. Okay. Thank you.
Senator Gulick has a question.
Yeah, I do. Thank you. So if someone has Alzheimer's, they are involved in a crime, do they follow the intellectual disability stream? No?
No, they would have to have a diagnosis of intellectual disability to be eligible for Act 248 in the Dale Commissioner's custody. So they would not be eligible based exclusively on an Alzheimer diagnosis unless they had an intellectual disability diagnosis prior to age 18.
So how would someone be handled in that
Well,
instance?
we'll have to ask the court that question.
Okay.
Yeah, some of this is out of our pay grade, but I don't know if you can define thoroughly every condition and every intervention. But so if it were a person who committed a serious crime who has Alzheimer's, how would Dale handle that?
They would not be.
In front of the court.
They would not be eligible, Senator, for placement in Act 248. So it would not be an option for the court to commit them to the commissioner's custody under the law as it exists. Similarly, for someone who has a traumatic brain injury, for example, it's a very limited population that is eligible for Act 248 commitment, and simply having an Alzheimer's diagnosis and committing a crime is clearly a problem, but it's not solved through the Act 248 commitment process.
Outside of this. Okay.
Thank you.
Hopefully we won't see that. That's
Right,
possible.
hopefully.
I know, there is violence. Okay, so.
Katie has another chart.
Venn
You ready?
diagram.
Yes.
I know, and she was working on it really late last night.
Oh, I'm sorry, Katie.
But this is really helpful, you know what? So after you've been involved with this stuff for a while and you understand it, you don't realize the need for this clarity, and this is really helpful.
Okay.
Then, I recognize that.
So I'm actually gonna skip us to the second page. The first page, it actually looks like language got cut off. I'm sorry, I was doing these, updating them so quickly right before I ran over here.
Okay.
But I will clean up the charts and.
So we're on page 2?
Yes, but page 1 is here because there's been a lot of conversation about what a competency restoration model would look like and what the proposal is. So I did a slide on it, but then I started to worry that we might muddy the waters if we're talking about a sort of a separate program.
Yeah.
So you have it if you would like to look at it, but I'm going to skip ahead to the admission to a forensic facility. So a person can meet the clinical standard for commitment to either the commissioner of Dale or the commissioner of DMH. And if they meet that clinical standard, they have that clinical need for treatment, then they're committed to that person.
Bless you.
Bless you. There are also persons who are found incompetent to stand trial for a crime with which there's no right to bail, or they're adjudicated not guilty by reason of insanity for a crime for which there is no right to bail. That's the standard in the forensic facility bill. Just because somebody is found not competent for or adjudicated not guilty for one of those crimes on the grounds of having a mental illness or a developmental disability doesn't automatically mean that they're a person that's going to meet the medical standard of needing commitment with the commissioner. So where the forensic facility comes into play is in the center, so the person is meeting a clinical standard of needing care. So they are in the custody of the relevant commissioner. They were either adjudicated not guilty by reason of insanity, or they were found incompetent to stand trial for a crime for which there is no bail. That's the standard in the bill. And there was also this recommendation that the person be placed in a forensic facility. That's part of what the commissioner is asking for when they're petitioning the court. So I just want to be clear that just because somebody is criminally justice involved and meets the clinical standard for need doesn't necessarily mean they're going, that they're eligible for the forensic facility as this is drafted. Just because a person is found incompetent and they've committed one of these crimes doesn't necessarily mean that they're eligible for the forensic facility as this bill is drafted. It's sort of the combination when all of these pieces come together, that they have been found incompetent or adjudicated not guilty due to mental illness or developmental disability for this set of crimes that's outlined in the bills. A court has determined they have a medical need, and a commissioner has made a recommendation that the forensic facility is the right place for the person.
Okay, so I'm looking at the language in the center box. It says adjudicated not guilty by reason of insanity or found incompetent to stand trial for a crime for which and we recommend.
That makes sense. And can I ask a question?
Yeah, no, that's good.
The crimes that for which there is no right to bail are what are called like the Big 12 or something, right? I know that's an Eric question.
Yeah, I don't feel comfortable answering that. But if you would like to talk about crimes, I'm sure you'd be happy to talk about crimes. I can pull the list up for you, but beyond that, I couldn't.
I think that's what it is. It's like the most egregious crimes don't have the right to bail. But
that's what judiciary is.
Yeah.
Brought to the table. And then brought us the rest.
Okay.
So let's go through it one more time. Can we do that? Talk about the Venn diagram very briefly.
The Venn diagram?
Yeah, just really
again?
briefly. Okay. So we have some clarity.
Okay. I hope it's clarity and not more confusion.
No, it's good.
Really
good. Yeah.
No, this is really helpful. That covers the combination of the things you're doing here and then the reorganization of the bill. It's terrific.
Well, good. Okay, so just to sort of reiterate what's in this slide, there is a population of persons who are criminally justice involved who will meet a clinical standard of need and be committed to a commissioner's custody. There is a population of persons who have committed one of the crimes outlined in your bill. They have been determined not competent, either due to mental illness, developmental disability, or adjudicated not guilty by reason of insanity for these crimes. But they are not meeting, a court has decided they're not meeting the clinical standard of care to be in the custody's commitment. And so both of those populations, if they don't have both factors, are not candidates for the forensic facility. The individuals who are eligible for the forensic facility are the individuals who are meeting the clinical standard of, they're meeting the clinical standard for need of commitment. They were adjudicated not guilty by reason of insanity for one of the crimes or incompetent to stand trial for one of the listed crimes, and are a commissioner whose custody they're going to be placed in has made a recommendation to the court that this is where to place the person.
Okay.
You can see why it's such a thin line. I mean, it's really, there are a lot of.
And then how many people fall into.
Right, exactly.
Yeah.
Not many.
Katie, thank you. This is really helpful.
Okay.
And I want to ask our friends in the peanut gallery here, because we had asked also for some visuals about the facility itself, because it's helping to see the process visualized, and I'd like to see the facility, because there's the 9-bed thing.
Yeah, it's on our field trip, but you want to see it you wanna see the design.
Well, I'd like to see it before we have to vote on the bill, just so I
Yeah.
can visualize
Okay,
what we're
let's
talking
write that
about. And I think that they were gonna try to get some kind of a, like, floor plan that we could look at or something, I don't know, but.
Well, who has that? Stuart or Rebecca, who could get us a picture?
That would be DMH,
Yeah.
because it's a
That would
DMH
be- of
facility.
course it
We
is.
are
Of course
working
it is. I
on,
said all the wrong names.
no worries. Yes, we are working on it. We're, because it would require renovations. What we're trying to put together is what it would actually look like for you. I mean, we could show you what it looks like now, but it would look different if a forensic facility were in there than it looked now. So we are working with BGS and finalizing that. But I will check
Okay.
with the timeline.
Yeah, so I think, if we could see that sometime later in the week, next week, that would be helpful, because we do want to try and work on this bill and move it along. So if we could get that, that would be helpful. And then we are planning a field trip. Kiki's working on that. We're going to find a day when we can travel to Berlin and to Essex Junction. That would be good.
Because when you have that feeling where you're like, okay, this bill is starting to make sense to me.
Right.
But if my brain moves on to something else, it will stop making sense to me, and I need to like vote on it like in that sweet spot.
We gotta keep focusing on this one. I know, that's why we're gonna keep working on it, try to do it. Yes.
I'm not sure if this is the appropriate time, but since the witnesses are all
Here.
potentially lined up for potential, testimony and such, I was wondering if Ms. Farley could comment on the use of the facility at moments in time where there are no occupants or there's only one occupant. I'm just wondering if you thought that eventuality through and what your reaction from as an agency is.
Yeah, so I think the system really ebbs and flows. It ebbs and flows now. VPCH goes through periods where we are full and we go through periods where we are not. I think it's a delicate balance, right, to try to figure out the right number of beds for the system when the system is constantly changing. So, I would say it is something we deal with now. And it really just depends on what the needs of the system are at any one time. We do staff it so that it's ready.
Right.
Because you have to have the staff in the facilities. But it does happen now.
Okay, so as a follow-up, are there in the concept of the facility as you see it now, are there secondary uses for the facility so that the staff that's dedicated and the facility that's dedicated can have other purposes, or how would you approach that?
So the facility, so like VPCH right now, right, it's licensed just as a hospital, so we can't use it for any other reason other than a hospital. If this is licensed as a therapeutic community residence, that's the only way it can be used. Frankly, other hospitals, I guess, are a little more flexible in that they may be able to take voluntary or involuntary patients. Our facilities are involuntary only. So we are somewhat limited in who we can take. But certainly we do we're always thinking about, especially with the IMD exclusion coming, and thinking about how to best use the facility, what needs there are in the system.
And last question, who would be the director of this facility? Does it fall under the chain of command of someone who's already there, that this becomes like a secondary collateral duty that?
It would have its own director. We're still really thinking about what the staffing program would look like. So right now, the way VPCH is staffed is we have staff and then we have a medical team. Our medical team is contracted out. So we would probably continue to contract out our medical team. We would probably have some folks that overlapped and some folks that were assigned just to the facility, but there would be one lead. We hadn't yet kind of determined whether or not that would be under the VPCH CEO or if it would be another direct report to the commissioner. Right now, the VPCH CEO and River Valley both report directly to the commissioner.
Thank you.
Yeah, so, and I think one of our jobs in here will be to keep an eye on the staffing and the care that is in any facility like this.
I really want to support this bill, but it is hard for me to wrap my head around the possibility of this venue facility sitting vacant potentially for years at a time, or with one person in it. That just, given the tight times economically, it just seems fiscally very irresponsible. I am, what was my second point that I wanted to make? Can we see some data, like going back maybe 20 or 30 years, like how many people would have been potentially in this situation? So would have been in this facility. Do we have that? No?
That's a question for Dale and DMH. And perhaps DOC, because Department of Corrections has been, the jail has been the fallback position for folks with mental illness or developmental disabilities who have committed some of these crimes. And so the choice is, where does the court commit them?
Right.
Does the court commit them to jail?
Right.
Does the court send them to a residential facility secure facility where you need a 3 staff to 1 patient ratio? Does it send them back into the community? And so there are all of those choices. So the question is, who in the past would have been eligible? That's what you're asking.
That's what I'm asking.
And I'm wondering if Stuart or Karen or maybe Nick Demmel and DOC can answer the question. I certainly can't.
From a
Senator-
DMH, oh, sorry,
Go ahead,
Stuart.
Go ahead, Karen.
Should have raised hands. You know, from a DMH perspective, we just don't track data that way. So I don't know that we could easily come up with a number. When we think about it, it's more kind of our knowledge of the system and who we have right now that we think. But that wasn't like data we had somewhere. That was just kind of the knowledge of the system. So I don't know that we could easily pull that. We don't track it that way because we're not parties to criminal cases. So we don't necessarily, you know, we know about the cases that come to our attention, but we don't know about every criminal case, right? So I don't know that we could easily get that for you.
Yeah, and Dale certainly could look back through its history of individuals who have been on Act 248. But again, the decision to place someone in the forensic facility is very fact specific. It's not simply that they committed a certain crime. It looks at the clinical necessity as well. So trying to look back and determine, would this individual have been a candidate as a result of dangerousness and clinical factors, is really hard to recreate. We can, as Karen said, look at current people who are in the commissioner's custody and make determinations as to whether they would be eligible. I would also like to say that having vacancies in long-term care facilities is not unique and wouldn't be unique, frankly, to this forensic facility. As you know, we have nursing homes, residential care homes all over the state that are ready and available to provide the services when individuals come in to those facilities. But there are vacancies across the state in nursing homes and res care facilities. So I just think that that's important to keep in mind. And also, I want to be clear that while Dale has indicated that it may have 1 or 2 people per year who will be eligible for the forensic facility, I think that we're looking at 9 beds, and DMH would also have individuals. So I'm not sure that we would be looking at a facility that would be vacant or nearly vacant, but most likely utilized to almost its capacity.
Thank you.
Sure.
Senator Williams has a question.
Well, actually, just a comment, having
Okay.
been around
Senator,
20 or 30 years ago, in law enforcement, the criteria for commitment probably was different than we're looking at right now. The conditions have changed, so I'm not sure how accurate that data
Could be
would
helpful.
Yeah, well, just one, Stuart, I don't know that there are tons of vacancies in long-term care facilities and nursing homes right now. Right now, there's usually wait lists to get into for many of them. So, just saying, but, I think one of the reasons I'm a little nervous, or I don't know, that's not the right word, but have concerns about the size of the facility is because back to that conversation we were having about
the 9 beds were chosen because that's what the physical facility right now can handle, because it's a wing in an already existing hospital. The 9 beds weren't chosen because that's what the experience and data showed were necessary. And there's not flexibility, is my understanding, with those 9 beds. It's like either 9 beds or no beds because of the way the structure is, the facility is laid out. And that's why I wanted to see the plans for the facility so I could visualize that better. But isn't that correct? I'm remembering that correctly from previous testimony, more or less?
Is that a Karen Barber question?
I'm happy to take a stab at it. So I would say 2 things. You know, one, we are not tied to VPCH. And I think I've actually come in front of you guys a couple times and said we'd prefer you not name VPCH just in case we need to pivot and use something else. So it's not tied to VPCH, right? That was through COVID, you know, those units have sat empty. They've been empty for a while because we just haven't had staffing. So it seemed like units that were available and that could be used. So I just kind of wanted to say that again, we're not tied to VPCH. They have been empty for a while. In terms of how we use it, so, you know, the IMD, we are needing to phase down, right? We're under an 1115 waiver. There is a way for us to use those 9 beds, but there's not a way for us to really, because of the way VPCH is set up, there's A and B units and they share a nursing bubble. And then there's C and D units and they share kind of a nursing bubble and they're on kind of separate sides. It would be really difficult unless we completely renovated everything to use C unit and D unit in very different ways. It's possible, but you'd have to really rebuild the structure of it. And so that's why we were looking at the 2 of them together, because they were designed to be kind of together. And it's much easier to separate C and D from A and B than to try to, renovation wise, than to try to renovate just C and just D, because they need separate yards and all of those things. Does that make sense?
Yeah. Okay. Thank you, Karen.
Thank you. Yeah, no, this is very helpful. And if we can, well, we'll look at the plans and then ultimately we plan on visiting both places. So the secure residential and the secure forensic. Okay. Any other questions before we move on? I'm going to suggest that we go to 192 and we'll pass with apology. Is there anyone here who has recommendations to make on S189 or S197 today? I'm looking at you, Brendan. Okay.
We'll follow up next week on 197.
Perfect.
Early next week.
That's good. And then we'll carry S189 and 197 over. We have time to do that.
Sorry.
But I think it's probably best for us to keep our heads right into S192 and go through the bill together and see if there's some decisions that we can make.
So this is draft 6.1 that I'm pulling up. There are some changes.
And you're gonna correct all those big errors.
I already did. I forgot to Kiki. She's updating them now. So hopefully they should be fixed.
Wait, we're at 6.1. Jeez.
What draft is it
This
now?
is 6.1. You asked for some changes yesterday. So I've highlighted the changes. Do you want to go through the whole bill?
Hang on a second, I just lost it. Yeah, I mean, if there are things that we've already agreed to, let's go to the places that we have questions on first,
Okay,
and then we'll go through the whole bill.
okay.
Yeah,
Okay,
yeah.
so.
And there'll probably be places where we have more questions, but you can direct us to where you think we have questions, and then as we go through the whole bill, I'm sure we'll find.
Okay, I'm gonna stop on section 1 then.
6.1.
6.1, section 1, because this is the purpose and legislative intent. You've heard testimony about when the facility can be operational by and whether or not you want to name a specific facility. So right now you have, as legislative intent, that, both the commissioners of mental health and Dale could have people committed to the forensic facility or placed in a forensic facility. You also have language, that this will be open July 1, 2024, and that it would be a 9-bed unit of Vermont Psychiatric Care Hospital. So I think that sort of sets you up with a few decisions that you need to make. Again, this is purpose and intent language, but it should reflect.
Yeah, and I think this is where there's probably no way this could be open by July 1st, 2024. And we just heard Karen again reiterate that they wanted the flexibility that it be a different facility, so.
Oh, good.
I would think we would
Good
want to
with this
change
one?
that. I don't know what date we want to put in there, though. I'm not sure.
It's already in existence, though, right?
But not
Right,
for this
hasn't been-
purpose.
Hasn't been retrofit,
Okay.
hasn't been fit up. So, well, the Karen will, as we're going through this, where the date of July 1st, 2024, and the proposed legislative intent language, if you can give us a date right now, fine, otherwise, or otherwise send it off to Katie.
So I think Katie and I did talk about this a little bit. I think one of our concerns is that there's no fiscal note attached to this, right? It's going to, part of that, right? We don't know how much it's going to cost yet, but we can't open it until it's renovated, and we can't renovate it without money. And so there is no money right now. And so we are concerned with putting a date on it without having any money attached to it. One of the things we did talk about was maybe having it at the end of next session, so that if the legislature didn't allocate money next session, then we would have time to change the date. There's certainly no way it could be opened by July 1. There's really no way it could be opened by January 1st, 2025 either, which I think is one of the dates later on, because really we need both time and money to do it.
So are
And
you
it's where it
suggesting
is.
2025 or 2026?
2026.
Okay.
July 1st, 2026? Is that what you're suggesting?
Oh, we could do July, we could do 2025. Sorry, we're in 24. So the end of next session, so that you would know by the end of next session whether or not there was money allocated.
July
We would-
2025. Got it. Well,
Is there,
Katie has a comment. No, go ahead, Ruth, and then Senator Hardy, and then Senator Williamson.
is there a request or contemplation of money in the capital bill this year for this project?
There is no money in the governor's budget at this time.
I mean, if we need this facility, should we just be putting it in our budget? I mean,
That is a big question.
or in the capital, because it's a capital project, you know?
Bonded, it's his capital.
So,
Yeah, it's kind of what comes first, the chicken or the egg. So do you have a plan for what the facility's gonna need for construction work? So that somebody could do an estimate of cost? Or
Yes, we are currently working with BGS on that. They have been out to the facility, and we are kind of going back and forth with them about what we envision our needs are, so that they can come up with some kind of rough cost estimates that we can show to you.
So for our purposes, if we have a date in here of 25, and then the bonding goes forward and is effective 24, the renovation will still be going on during next year's session. So we can change the language. And that, I think you were suggesting that.
Yeah, so one of the things I talked about with Katie, but it seemed too unwieldy, was just having language that it would go into effect when it was properly funded, but that seemed unwieldy. And so we talked about putting a date on it that we knew we could change later.
But so were you gonna make that comment?
My concern with the contingent effective date, we do it sometimes, like the lead bill that you worked on a couple
That's
years ago
right.
had a contingent effective date. They can be a bit subjective, and it sort of leaves folks knowing whether the legislative language is in effect or if it isn't. If you were to choose a date certain that is in the middle of next legislative session or after next legislative session, that gives you the opportunity to amend the operational date if DMH comes back next January and says, we have a plan and we know at this point when it can be operational.
So July 2025 would do that. If it were April 30th, it would do the same thing.
Yeah.
Just push the discussion. Did you have a question?
So, yes, in the meantime, if a situation arises where you need it, what are you gonna use? You're gonna use that facility anyway, would you?
What we do now.
That's what you do now?
We would do what we do now, right? So if it was someone in DMH custody, we would look to see where it would be appropriate for them to be treated, whether or not it was in the hospital, the secure residential, or out in the community. From Dale's perspective, if someone comes into their custody for 248, they would use the mechanisms they already have. So we would continue a status quo.
Thank you.
Or jail. Jail is always an option, which is the worst place for folks with mental health issues to be.
And I would add, Senator, that for individuals with intellectual disability, it's probably the worst place for them to be. And currently, the only option, other than a community-based setting that Dale would have, would be that jail setting. So that's why we feel it's really important to have another tool in our toolbox.
Thank you. Okay, so the thinking here then is, rather than say when and if, to have the date certain that can be, that I'm looking at you for the best legal.
To me, that seems cleaner, to have a date certain when, when the language takes effect, knowing that you can come back and amend it if it isn't quite right. We do contingent effective dates. The lead contingent effective date, we had language that when, I don't remember if it was the Commissioner of Health certifies to the Speaker and Pro Tem that the EPA has approved certain language. I don't know. But I would get calls, is this language in effect yet? Have you received the certification yet? And it wasn't as clear cut. So, I mean, I think you can make a policy choice as to how you would like it to operate, but it seems that having a date certain that can be amended is a little bit more clear cut for everybody
Keeps it on the front
involved.
burner. So how many would like to see July 1st, 2025? Is that something we could consider? I'm all for it.
Yeah, then we can always change it.
Yeah.
Yep.
Okay.
Would you like the language in here about the 9-bed wing of the current Vermont Psychiatric Care Hospital? Would you like to be silent? Would you like to have an alternative?
Let's just keep it silent. Let's keep it silent. In a forensic facility. Well, if Act and Resolve 27, does that have 9 beds in it? I'm trying to remember.
What was that?
Does Act 27 reference the 9 beds?
I believe
Because if
we
it's
had-
there, then we don't have to put it in again.
I believe there was intent language. I don't know
Yes,
how
it was.
specific it
I
was.
remember
Let
what it
me
was.
do a little search and I'll let you know. Is the intent of the General Assembly that an initial forensic facility be authorized and operational beginning July 1, 2024 in the 9-bed wing of the current Vermont Psychiatric Care Hospital?
So if we cite it once in the Acts and Resolves, we don't need to cite it a second time. And just put the date in.
And then the other decision point here, and I'm not sure if you are ready to do that, is what is the population that is eligible for forensic facility? We could come back to that.
Yes.
Okay.
Let's come back to that.
Okay.
But I think we have our Venn diagram. I think we know what the intent is there. Okay.
Oh gosh, now I'm in last year's act. Let me find this bill. Okay. I'll pull this back up. Okay. So while I was putting together all of your charts last night and this morning, I felt like the language around the intention of having people eligible for the forensic facility who were incompetent to stand trial wasn't as clear and obvious to me as it could be. So this section 2, I've added proposed language that I think makes it clear. I'll walk through this with you, and if you don't like it, we can remove it. So this language establishes the Human Services Community Safety Panel. So the first sentence is that it's created within AHS. The panel shall be designated as the entity responsible for assessing the potential placement of individuals at a forensic facility pursuant to 4821. 4821 is sort of the hearing process for incompetency to stand trial, and you've, on this bill, proposed language that gives a process for the Human Services Community Safety Panel to operate on. And then we say for individuals who, so these are the people who are going to be considered for the forensic facility, present a significant risk of danger if not held in a secure setting, and are found not competent to stand trial for an alleged,
Which word goes? Which
yeah,
word
maybe,
stays?
for an alleged crime for which there is no right to bail pursuant to 7, so the same phrase you were using before. I'm gonna write a note to myself, page 2. Edit.
Does charged with need to be in there?
No, I have too many words. I'm competent to stand trial for an alleged crime. Maybe charge does need to be there. Let me play with it. But the idea is to embed the not competent to stand trial right in the language to make it a little bit more obvious.
B already has
Charged
charged with
is
a crime
nice, yeah.
for which bail is not available.
Charged for a crime.
But that's and adjudicated not guilty by reason
Oh, I
of
see what you-
insanity.
Yeah.
Yeah,
Okay.
so we have like an A that I think is trying to get at incompetency, and then the B is the adjudicated not guilty by reason of insanity, but it never says exactly not competent to stand trial.
Yeah.
And the or is important between A and B.
Yeah, so let me clean that up. I have too many verbs. But that's sort of the concept, if you're comfortable with that being added there.
Yeah, no, I think that makes a lot of sense.
Okay. Next, we move into the process and that the panel will follow, that they will conduct a review in certain circumstances. If they don't conduct a review, this is the process to ask for them to conduct a review. When they conduct a review, this is the criteria they're going to be looking at. So no changes here. And then we move into all of the mental health language. Should I move through this? You sort of want to get to see the new language that you asked for yesterday. Okay. The only real change in the mental health section from what you saw yesterday, if you remember, we talked briefly about involuntary medication, and we added the secure residential recovery facility as a facility where involuntary medication could be provided. Upon further investigation, they already have that authority in this subdivision 2. What they don't have is the rules governing the secure residential recovery facility. They don't have in the rules the authority to give involuntary medication. So the authority is statutorily provided here. So I've instead just added to the rulemaking directions to amend the rule to allow involuntary medication, because I don't think we have to add it in statute.
I think it's really very important.
Yeah, so this is, this gives permission to the commissioner to apply for voluntary medication for a person who has previously received treatment under an order of hospitalization as under a current order of non-hospitalization, including a person who resides in the secure residential. Okay, so there's no highlighting because I took out what was added. And then that brings us to our individuals with intellectual disability. And that's the second part of the bill. So the big change you are asking for is to line up commitment under Act 248 with the commitment timelines in the mental health statute. My voice is in and out here. So In subsection A, the court finds that a person is a person in need of custody, care, and habilitation. The court is to issue a commitment directed to the Commissioner of Dale for placement in a designated program and the least restrictive environment consistent with the person's need for custody, care, and habilitation for up to 90 days. So that the initial order for commitment and under DMH they would be parallel here.
Oh, I've been waiting to do this one. This is good.
Are you being sarcastic?
No, that whole working group, please.
Okay, there are conforming changes that go along with that. So let me get you there. So this is section 8845. And this section again has to
Page?
23. Thank you. This again is the initial order for custody, care, and habilitation. And we have language here that if the court finds by clear and convincing evidence that the person is a person in need of custody, care, and habilitation, the court shall order that person to be committed to the commissioner and receive appropriate treatment and programming in a designated program that provides the least restrictive environment consistent with the person's need for custody, care, and habilitation for up to 90 days. So that's conforming change, what you've already seen. Our next section is the continued custody, care, and habilitation. This language had to be adjusted a little bit more. So if prior to the expiration of a previous commitment order that was either issued in accordance with Title 13 or this subchapter, the commissioner believes that the person is a person in need of continued custody, care, and habilitation, the commissioner shall initiate a judicial review in the family division of the Superior Court. And then, the address. I have done some research. Let me just skip over that for now on page 26. The petition shall include, skipping down to subdivision that lists the what has to be in the petition, and then in subdivision 2, notwithstanding subdivision 1, a person may initiate a judicial review under this subchapter at any time after 90 days following a current order of continued commitment. So I've made that change because if you think it through, the initial order can only be up to 90 days. So it would be silly to have somebody petitioning after 90 days of the order if the order can only be up to 90 days. So now this is saying that the judicial review that a person can initiate would be following a current order of continued commitment, because the order of continued commitment could be up to a year. Should I say that again?
No,
Okay, we're good.
we got it.
Okay.
Oh, wait,
Can we go back, to 25? Said,
Page 25?
no, yeah, under, petition and order for continued custody, care, and habitation.
Mm-hmm.
Says, in accordance with 13 VSA section of this, or this subchapter.
Mm-hmm.
So what takes, does it matter what takes precedent?
It just sort of matters where somebody is in the process. So as you remember the flow chart we looked at? So somebody is sort of starting in the criminal division. They're criminally justice involved. There's a forensic evaluation. And so their initial order is going to be under Title 13, the criminal justice title. But after that, all of the process for holding somebody in the custody of the Commissioner of Dale is going to be in Title 18.
Okay.
So that cross-reference is really just meant to be inclusive of wherever somebody is in their process.
All right, so Title 13 doesn't need to be amended because of what, this language here, right?
No.
Okay. Got it. Thank you.
Yeah, thank you. Okay. And then there's a new subdivision 3, that any commitment order for custody, care, and habilitation or continued custody, care, and habilitation that's issued, same cross-reference, Title 13 or this subchapter, shall remain in force pending the court's decision on the petition. So that is same language as what we have in mental health, but if it's day 88 and the Commissioner of Dale submits a petition to ask to be able to continue to hold this person in their custody, then the the 90-day order stays in place until the court has made a decision on the new petition.
Is there a timeline for that decision-making by the courts in 13 PSA 48?
I'm not sure.
I don't know.
Yeah, I was thinking the same thing, because the courts could take a really long time, and then their commitment that was originally 90 days could end up being a year and a half, because the
There
courts.
may be, we'll have to check with Eric.
It might be worthwhile to ask how it's working in the DMH context,
Yeah.
because they have the same language.
It is the same.
Is Karen there?
Oh, we can look it up.
Yeah, so as I think as I had indicated last time, there is a court case on point that says that it expires after 90 days, so they have to make a decision. But what the other thing we do is we file in family court. So the family court, after those 90 days, the family court is making a decision. So we haven't had that issue, but jurisdiction does switch to the family court.
That would be the same case as this is drafted. The initial order would be in the criminal division.
Oh, and then it would go.
It would be family division.
Yeah, we haven't had any issues with that, Ben. I don't know, maybe things just happen more quickly in family court, and maybe because they know their custody cases. We just haven't had that issue.
It hasn't been an issue, but maybe it's a question we can ask of judiciary and what they're hearing. Because if it's a backup, it's a problem, and people are standing out there waiting. We don't want that to happen. Okay.
What a document.
Yeah, I think just flag it for us to ask Eric about, or
Okay.
to have judiciary
Yeah.
look at, because.
Okay, I'm just gonna go back up to what is included in the petition, and I struck and address. So I went back after you asked your question. It's like, I pulled this from the mental health language. Let me see what this looks like. So in that context, they're looking at the information, the applicant's information. So the person who's submitting the application, that another person should be committed.
Oh.
And so maybe an address makes sense in that context, but I could understand that in this context, maybe less so, because this is talking about who the petition is for. So I struck it. If you would like to keep it, you can, but I wanted to bring that to your attention.
Is there any reason for it? And I guess Stuart is the one to answer this question. Stuart, is there any reason to leave address in there?
Probably not. I think the question that Senator Hardy had was, these are all people who are at the forensic facility, so why would we need to include their address? But in looking back at this section, it's actually for anyone who's committed to the commissioner's custody. So they would be living in the community at this time. So the individual's address might be relevant. I'm not particularly wedded to it either way. I'm not sure it's necessary to include where the person resides in the community, but I think that's a policy call.
It would be, if it were an ordered commitment, you'd have to know where they are. If they're out in a residential environment, you'd want to know where they are.
Sure. This is just the petition, though, that the department would file, and whether the commissioner would need to include that in, and maybe the court wants that information, so maybe it is a good idea to include it.
Yeah, I mean, it could be Brattleboro and they're up in Rutland or something, I don't know.
I mean, my question was about people who
Yes.
are already committed, and their address would naturally just be what the facility
Right.
was, but.
If we know it's a single institution, that's one thing, but when it's community support services, it's different. So we'll leave it as yellow for right now.
Yeah, I mean, I don't have strong feelings about this. I just
either.
wanted it to be logical and necessary.
Okay. Okay, anything else, Katie?
Yes, but do you want me to, is there a decision on this? Should I?
So how many would like to take the word address out? How many are okay with leaving it in? Okay, we'll leave it in.
I didn't vote, so.
Well, how many?
Majority.
Well, we have-
I don't,
How many would like it out? Or how many abstain, I guess? How many would like it out?
I don't care that much. I just wanted it to be logical.
Okay, well, let's just leave it in for now, because you've got people who are in different parts of the community, and if that turns up as an issue,
Okay.
we'll continue on.
So then we have language. Do you want me to sort of just highlight decision points for you? So we have language about placement in a forensic facility under, a petition for continued
Can we,
custody care and
you don't
rehabilitation.
have it up on screen,
Oh,
Yeah.
yep, okay,
please?
thank you. So this is language, bottom of 26, top of 27, and this is the piece I have flagged every time we've been through it, that, you know, when was the last Human Services Community Safety Panel done? Maybe we have maybe you have a different response, knowing that the initial order is shorter now, 90 days, or maybe you want them to redo their recommendation after, you know, before every petition for placement is filed, but I just flag that as what is the timing there?
Uh-huh.
Should it be the most recent recommendation?
Well, what's feasible? Is it a 30-day period? Is it a 10-day period?
What you're asking, Katie, is there's the initial recommendation from the Human Services Safety Panel.
Yes.
And then are they required to make another recommendation? Or is it just one recommendation that then just holds?
You know, the language, I don't think about the panel doesn't necessarily say they have to make continuous recommendations.
Yeah.
But this language says that when you're applying for continued treatment, you have to have the recommendation of the panel.
Right, so I
That's
think
right.
that their recommendation could change though, because
Yes,
after
it could.
somebody's there for 90 days, maybe they have been rehabilitated.
That's why
And then they don't need to be there anymore. So if we're asking for a recommendation from them, if it's.
the panel is required on what we have earlier, the panel, in the bill, the panel is required to make that recommendation.
So I think they're gonna have to make a second recommendation.
Yes.
Or third or fourth,
Well,
depending on
100
however many.
Every year, every 90 days.
A renewed recommendation?
So the timing of, so if one,
Could give a time frame within 10 days of the filing.
Gotta
of the
be,
petition.
so these people who are on the folks who are on the panel are not inaccessible from one another. The meeting could be called expeditiously within a 10-day period. Or, okay, Stuart, I'm going to lean on you again, think. Or Karen, or both. So the panel, the review panel, how frequently will this panel be meeting?
I think it will meet as needed, Senator. So if there's a recommendation from either commissioner, then the panel would convene to make a determination and to conduct that assessment. And it's not simply a question of, there would have to be assessments done as well. So it is a rather extensive process to ask that the panel meet every 90 days would be probably quite a heavy lift, even though we are only talking about a few individuals. There are the clinical and dangerousness factors, and there are assessments that need to be done.
I think the thing to remember is that the state has the burden, whichever custodial commissioner has the burden to prove to the court that it's the least restrictive setting. So while the panel is going to meet initially, the commissioner could seek to put someone in a forensic facility without the panel, right? And ultimately, it's the commissioner making the decision, and the commissioner's not making the decision without pulling on the clinical expertise of their own folks. So there is always going to be an analysis and an assessment done, regardless of whether or not the panel meets. And I would agree with Stuart that it's kind of a heavy administrative burden when there's already a burden on the commissioner to prove to the court why the continued confinement at a secure setting is the least restrictive. So that has to be met regardless of the panel. And so to me, that's enough.
Yeah, I think we can get rid of B.
Panel?
For the re-upping. They have their initial thing that they do.
Can we, yes, I think that's really the point, whether the panel is engaged in this process here or not. You're right. So the question, what I'm going to do is we have another issue on our agenda. We're really getting into this thing. in a good way. Is this something that the two of you, Karen and Stuart, you can ponder on for us, but then also we need to ponder on this, and Katie, with Katie. So is it the best solution to take the panel out of this place, or is this a protective factor for patients, dealing with them as patients, to have that review and to have that other assessment? Go ahead.
I guess
Wait,
I would say.
I've got
I'm sorry.
another comment here, so
Sure.
go ahead. Thank you. No, it's okay.
Just food for thought on that piece is that this might be the first time somebody is going into a forensic facility. It's possible that a person was committed to the custody of Dale. They've been under their initial order. Maybe they've even been under some continued orders in the community. But at this time, the commissioner is asking for a forensic facility. So in
Under
that
those
case,
conditions, the panel must be involved. We should, might should.
food for thought.
Could be somebody else's should.
Yeah, maybe
Okay, we
we
need to ponder on this one a little bit
Get a little
more.
more testimony.
Yeah, we're gonna have to,
Go faster.
well, we've got, Brendan, are you here for the update?
I won't be presenting, but I'm here.
Okay, so, we've gotten to a very sticky place.
Why don't I go over the last few places that are
Please.
highlighted, and then I
And we're
will,
gonna have to do
I
our.
will be done. So there is a question about court timeframes for a hearing, which you may or may not want to discuss at some point. And then we have our commitment language for continued commitment. So we have that language up to 1 year for the continued commitment. And then there's a question that I referenced yesterday that Stuart had a question on this subdivision B about whether a prosecutor would be an interested person or a party with regard to being able to comment to the court about a person's discharge from placement from a forensic facility. I drafted it as an interested person after talking to the judiciary team, but they did indicate that this was a policy decision, so I wanted to flag that for you.
Is it our policy decision?
Or is it next door?
Right, I mean, the prosecutor would seem to be next door, but we'll make our recommendation and see.
Okay, and then, what is this? I fixed the lack of the word within on page 31 that we caught yesterday. And rulemaking. So there is a request that the rulemaking be pushed back to August. I was directed to go ahead and put that in. So this rulemaking section has to do with amendments to the therapeutic community residence rule. There was already language in the bill about adding a forensic facility section that would allow for emergency involuntary procedures and involuntary medication to be given at the forensic facility. And this is what I was sort of suggesting previously about the secure residential recovery facility and involuntary medication, that we don't need it in statute, but you would need to amend the section of the TCR rule on secure residential recovery facilities to allow for the administration of involuntary medication if that is your policy choice to do so. So that is added there. And then we have the effective dates, which we'll need to focus on at some point. Okay, that's it.
This has really been helpful.
Oh, good.
No, but we do have some difficult decisions to make as we go through.
I just have a request. Well, first of all, thank you. Yeah, this has been really helpful. I know that our visual things were a pain for you. They did help, so hopefully that makes it sort of worth it. I just want to request that we not have a new draft next time, that we stick, because I'd like to go through this really more detailed. And every time there's a new draft, I'm like, oh, shoot, you know,
Well,
there's
this-
some more
yeah,
changes.
the
So if we could just
recommendations
hold
that are
off
here-
on doing these changes until we,
Okay.
that would be helpful.
Yeah, the
Mark the
recommendations
changes
that
in
we
my
had
copy.
here
Yeah.
were some that we had talked about, whatever day it was yesterday. Anyway, and Katie worked really hard to bring us some of this in connection with, Dale and DMH, but I agree, let's focus on this for now.
Okay.
And if there are people who have suggestions for change, we'll have to bring those in after we've been through, or as we go
And
through.
we're not doing this tomorrow again, are we?
I don't think so.
Okay, so I have the weekend to
Yeah,
try to remember to go through this draft.
gonna have a quiz on it. Who has their hand up? Stuart, you have your hand up.
I do, thank you. I see that there are some suggested changes, and I was just hoping that Dale would have an opportunity to comment on those. We have some significant concerns about some of these changes, and I'd just like to briefly comment when I have a chance to do that.
So here's how we're gonna proceed. The committee has just barely gotten its feet on the ground with the bill itself. But we're going to go through the bill, one decision at a time. We might come back to the more difficult. Who's that?
It's really a pleasure to be here to be back.
Oh.
For a few reasons. One is that I have not heard
Hello?
so much reasonable.
My apologies.
Okay, so we're gonna go through the bill, and yes, we need you and Karen, for a lifeline out there, we'll have that discussion. The committee will ultimately make its policy choices on some of these things. Okay, and I know there'll be others who wanna comment, that's not off the table at all, so thank you.
Thank you.
A lot of work overnight. And we appreciate it. So our assignment is then to go through the bill and we see where there's some real difficult decisions we have to make, and then we'll hear certainly from people who are directly involved in how that our decisions fit with their thinking. That's what we are. Okay. Oh, what a terrible thing to do to the Department of Health. We have, well, we have hub and spoke expansion on our agenda for 15 minutes. I had originally intended it would be a little bit longer, but why don't we do that? Are Kelly and Tony on?
Yes.
There you are. We're a little bit late, getting to you, but we would like, what we're asking for is an update on the hub and spoke expansion and how things are going, and welcome.
Thank
So,
you.
how do you want to proceed? Are you two want to testify together, or Kelly, you gonna?
I'm gonna go through our presentation, and then Tony, as our state opioid treatment authority, is available to answer any questions that that come up or that I am not able to address.
Can I ask you this? I know that our time is pressed right now. We are going to be taking up recovery centers and looking at other issues related to opioid and other substance use disorders. So this, if we can just get a beginning update, and then we may invite you back.
Sure. And I believe you heard from Dr. Saroyan last week about the spoke component. So I was going to talk specifically about the hub component. And I did send slides to Kiki just about an hour and a half ago. So I don't know if you have them in front of you.
We have it. We have it right in front of us.
Oh, great. Okay. So, so I will go through these slides quickly and happy to come back to talk in more depth. But, you know, I'll start with slide 3, which is just sort of some background on the expected impact of the hub expansion. And just to refresh your memory, the idea behind this was to offer treatment for other substances in the hubs or methadone clinics, as well as expanded mental health and physical health services. So the expected impact is that, you know, more emphasis on co-occurring care and expanding sort of the breadth and depth of services that the hubs provide. I do want to note that hubs already do work with other substances. I don't think it's necessarily consistent across all of the hubs. So this will sort of provide them with more resources and training and protocols and things so that we can sort of make that a little bit more the standard of care in the hubs. So you can see that we're enhancing training opportunities for hub providers, allowing them to treat co-occurring disorders, increasing the hiring, retention, and staffing of healthcare workers to expand these services. And we're developing a standardized menu of services that all hubs would offer. So Act 78 provided us with funding to do this expansion of the hub services as well as the spokes. And this was per Act 78 of 2023. And so we were given almost $4.6 million from Global Commitment to do this 2-year pilot expansion. And what these funds would be used for kind of fall into 2 categories. So hub services are, they are paid on a per member per month basis. And so integrating some of these other services, we will increase the per member per month reimbursement rate for hubs for doing these additional services for those that are eligible for Medicaid reimbursement. And then the things that aren't eligible for Medicaid reimbursement, such as training and curricula and other materials, we would pay for that outside of the per member per month. So to date, we've done a lot of planning activities for the hub expansion. So we have developed a future state design, which basically is a planning document that outlines sort of milestones and goals and objectives along the way and key activities for implementation. There's been significant engagement with the hub directors and medical directors to develop the enhanced services menu. We asked them to rank each proposed service based on, several criteria and propose additional services. And so we distributed those results back out to the hub directors and medical directors and solicited feedback to develop the final menu. And then we have an implementation roadmap, which details specific actions and timelines for each phase. So right now, the hub services menu is in the process of being approved. And we are working with our business office to map out sort of the cost estimates for the per member per month and the other expenses. Not specifically related to the hub expansion, but we have some complementary activities that are going on. So through the opioid settlement dollars, we provided grant funding to the hubs to deploy outreach workers to help engage people with treatment. We also issued grants for providing contingency management, which is a treatment modality primarily used for stimulants. That's sort of an incentive-based model. So it's trying to expand the contingency management opportunities through the hubs. And we also are implementing hepatitis C screening and treatment in the hubs. We are also working with DOC for a satellite dosing location in one of their facilities with their healthcare vendor. And we are in the process of reviewing the RFP responses for the other 3 satellite dosing locations that are being funded through opioid settlement dollars. We've had significant stakeholder engagement through this process, including with, again, hub providers, the Department of Mental Health, and the Blueprint. We have developed not just for the hub expansion, but for all of our SUD sort of initiatives that we have going on in our system of care. We developed a steering committee, which is an advisory group for all of these initiatives. And they include stakeholders from, of course, the Department of Health, DSU, DMH, Blueprint, the Medicaid Policy Unit, the Department of Corrections, and DEVA. So we just had our first meeting of that group last week. DSU facilitates monthly meetings with all of the hub directors and medical directors to make sure that there's coordination and alignment. And, you know, it's an opportunity for them to ask questions, seek support from, you know, Tony and his team. And we also facilitate sort of like knowledge sharing sessions between the hubs. And then the hub expansion, specifically 2-year pilot, is informed by input from Vermonters with lived experience with opioid use disorder and navigating that treatment system. So this includes from learning collaboratives, evaluations that the hubs do, recovery, engagement with recovery centers and recovery coaches. And we are developing a stakeholder engagement and communications plan to inform all stakeholder entities of progress timelines and changes. So as we look ahead, we have some things in front of us to sort of move this initiative forward. We will work with rate setting to increase, like I said, that per member per month rate. And that also is going to require engagement with the payment system through Medicaid, the MMIS system, and with Gainwell, which is the MMIS vendor. We will be executing grant agreements with the hubs for the service enhancements proposed as part of this expansion. We will coordinate with the hubs to implement the enhanced services menu. Like I said, that includes expanded mental health and physical health services and polysubstance use treatment. We will be evaluating this initiative by collecting and analyzing data so that we can measure the impact of that this initiative has had on the populations that the hub serves. And then we'll monitor and track all of the implementation activities, including the service enhancements, and continue to coordinate with our internal and external stakeholders to make sure that we're addressing any challenges with implementation and that we're monitoring progress. So the last thing that's part of this presentation is just a location map of where all of the hubs that serve. We have one on here that's in New Hampshire, but it's right on the border in West Leb. So these are the hubs that are essentially in Vermont. There is a hub down in North Adams, Massachusetts, an opioid treatment provider that some folks from the Bennington area travel down to for their methadone treatment, but we are in the process of working on opening a hub in Bennington that hopefully will open this year. So
as soon as it gets its CON.
Yes.
Yes.
Yeah, so they are working on that, and they have a location, they have a contractor. So we're seeing much more light at the end of the tunnel than we have over the last several years. So you'll soon see another orange dot pop up on this map.
That's terrific. Thank you. You actually went through a lot in a short time. We have a lot of questions, I know that, but what you have done for us is to set a stage on where you are with the pilot program. I'm going to ask 2 questions, and then there are others who may have a question, but we're obviously going to have to bring you back as we go through some of our recovery center discussion and opioid treatment, and I know both of you will have a lot to share with us. But my first question is, now we've got the 2-year pilot going on, and you've just started structuring the evaluation and the whole RFP process. So when does it begin, and when do we have data coming in Because I know there's a lot of anxiety and interest about getting results, but results don't happen until you've got everything set up.
Right, exactly. So I'll have to look at our implementation roadmap unless, Tony, you know off the top of your head what the target is for actual having the services in place. Oh, can't hear you.
You're muted. You're muted. How's that? He doesn't say anything.
You could actually hear him.
Turn your sound up? I don't know. He can hear us.
He might have his headset plugged in.
Or the settings, yeah, the audio settings, Tony.
You could barely hear him.
Oh, we could
Good.
barely, some of us could barely hear.
Go to the settings in Zoom, Tony. You may be able to adjust.
Well, let me ask my second question, and then as Tony gets the sound sorted out. My second question is, as this is going on, obviously there are privately insured folks who would be accessing Hub and Spoke. How are you discriminating between the, the payment model or the payment and the money from private and our public programs? Are you doing that?
Yeah, so certainly folks with private insurance are served through the hubs. I can't speak to how each insurer pays for those services, but the PMPM is obviously for Medicaid and how we've structured Medicaid payments to the hubs. But the services that are available in the hubs would be available across the board.
So do we have any understanding? I know this is outside of the pilot. It's not a pilot, but do we have any understanding of which and if insurance companies are doing a PMPM, a payment per member per month?
I don't know, but I can find that out for you.
Okay. Tony, I can see that you're very frustrated by this process. I hear you. All right, so here's what we'll do. We have you up for another time. There will be a lot of questions, and we appreciate your coming in and giving us this initial update very much.
No problem.
Mr. Hardy has a question.
Thank you, Kelly, for your update. And I know that you are working really hard. I know that from all of the work on the opioid settlement committee. I have also reached out directly to you and several times to the commissioner, asking for a meeting with you and the commissioner and with Mr. Folland about the hubs and the satellite hubs. And I have yet to hear from you about that. And it is very frustrating. The delays, the continued delays on the Bennington site, the lack of flexibility in the RFPs for the satellites, that is very frustrating given the severity of this crisis in our state. And I'm obviously frustrated, and I've talked to the commissioner several times, and so I'm asking you now on the record in public, could you please respond to me with a time to meet? Thank you.
Okay, and so we'll thank you for that, and we will have you back in. And hopefully by that time, the CON discussion will have been settled at the Green Mountain Care Board, and the Bennington will be open. So we're gonna call it a wrap for the day.
Okay, thank you.
And